A very good evening to all of you, and thank you all for being here on a Saturday evening. And today we hope that we will be able to justify your presence here, and you will go back with some really incredibly thoughtful food for thought, which will definitely enhance your clinical practices respectively. By way of introduction, I'm Dr. Amit Bhargav. I am heading the medical affairs at Lupin Limited and also have a small family physician practice in Goregaon in Mumbai. And the speakers for the day, we have two very renowned people from the United Kingdom. First to take the floor will be Professor Naveed Sattar. He's Professor of Metabolic Medicine, University of Glasgow, Scotland. And the next, that will be followed up by Professor Melanie Davis, whom a lot of you must have already seen in India in a number of occasions. She's Professor of Diabetes Medicine, University of Leicester, UK. In the Indian luminaries that we have got people from 4 specialties. Needless to say, the endocrinologist here, as you can see on the screen, is Dr. Sambit Das, very well known in the field of endocrinology. He has been scientific chair for a number of conferences. He's Senior Consultant Endocrinologist, Endeavour Clinic, Center of Diabetes and Endocrinology at Bhubaneswar. From the field of cardiology, we have another stalwart, Dr. J.C. Mohan, who's Chairman and Head, Department of Cardiology, Jaipur Golden Hospital, Delhi. And he was also former Professor of Cardiology, G.B. Pant Hospital. And incidentally, he is also my teacher, and I respect him a lot for the wonderful lectures that he took when I was an undergraduate. Thank you very much, sir. Dr. Deodatta Chaffekar is the nephrologist in our panel. Once again, a very renowned personality, senior consultant nephrologist at Supreme Kidney Care, Nasik. And last but not the least, Dr. Arjun Khanna, also from Delhi. He's senior consultant pulmonology, critical care, allergy and sleep medicine, and at Yashoda Super Speciality Hospital, Ghaziabad, and Galaxy Hospital, New Delhi. He's attached to both those hospitals. So in order to provide us with the different perspectives, because now these days we know that, there is a lot of interplay between endocrinology, cardiology, nephrology, and now with COVID coming up, there's so many hypotheses that are going around with DPP4s, with ACE receptors and all, the statins. And so there needs to be an expert opinion from the field of respiratory medicine also. Thus our panel. So with that, I will stop, and straight away we will, I would like to invite Professor Naveed Sattar to kindly let us know some of the important developments at EASD. And just a little housekeeping announcement prior to that. I'd request all the panelists and the speakers that during the question and answer session, as far as possible, try to limit your answer to 1 to 2 minutes. So that way we'll be able to pack in that much more. And of course, there would be times when we need to talk a lot more. But please use your discretion. With that, the importance, this incidentally, for the benefit of those who don't know, this webinar is being telecast on Facebook also. So there are going to be a lot of doctors. In the last one that we conducted, we had more than 5,000 people viewing it. Of course, how many stay for how long is another question. But the importance is that these are all doctors, right from a GP to a consulting physician to a super specialist. And they're looking for answers to enrich their clinical practice. So as far as possible, if we can keep all the discussions to be clinically relevant, that will be a real icing on the cake. So with that, over to you, Professor Sattar.
Okay, thank you very much, Dr. Amit. I'm going to share my screen right now and then crack on because time is of the essence. So thank you. It's a great pleasure to join you from Glasgow. The sun is shining in Glasgow for a change. So EASD updates. So I had the pleasure to actually, before I start, I had the pleasure to do the Golgi lecture. And in the Golgi lecture at the EASD, which you can still view online, I think because it was a virtual conference, it was somewhat different, and all the lectures are online. So if you have membership of the EASD, you can go back and view these lectures for up to a month. So in the Minkowski lecture, I talked about the pathophysiology of diabetes, and we'll come on to one of the papers that I'm going to discuss as part of this. Anyway, let me start with the Carolina program. So cardiovascular and hypoglycemic outcomes across age groups in people with type 2 in the Carolina trial. Carolina, to remind you, compared linagliptin 5 milligrams versus glimepiride 1 to 4 milligrams once daily on cardiovascular and hypoglycemic outcomes. And this particular sub-analysis or secondary analysis looked at these results by age groups. As you know, the primary outcome was 3-point MACE, secondary outcomes, mortality, changes in hemoglobin A1, weight, and hypoglycemia. So what did they find? The top line is the following. So when they looked at 3-point MACE, which is the top, you can look at by less than 65, 65 to under 75 and above 75. There was no difference in glimepiride versus linagliptin in terms of the primary outcome. So p-values, there's no evidence of heterogeneity. The same for CVD death, the same for non-CVD death, and also the same for all-cause mortality. So whatever the age, there was no difference in the in primary outcome or secondary outcomes in comparing glimepiride or linagliptin in the Carolina trial in people with diabetes and cardiovascular risk. What about time to first moderate severe hypoglycemia? Now you can't see the top, but effectively, again, the statistical way to look at this is interaction. There was no difference. So that basically means the patterns which showed that in the yellow, let me look at for example, look at the less than 65. Those people who are less than 65 who were on glimepiride had much more moderate to severe hypoglycemia compared to those who were given linagliptin. And the same in 65 to greater than less than 75, and the same greater than 75. But that pattern was identical. The more important data I'll show you in the next couple of slides is in the table, is looking at the real severe hypoglycemia. Was that different? And my gut feeling is it looks slightly different. What about change in hemoglobin A1C? With both drugs, you notice that there's an early decrease and then it tails off. So the values go back up. But values always go back up when diabetes, because people age and they often, the pancreas becomes less plastic. Notice there's an early benefit for glimepiride, which is lost around about 1 year overall. And you see that in each of the 3 age groups, the youngest, the middle age group, and the oldest age group. There is some suggestion that the oldest age group do the best in terms of glucose lowering, but that might also portend potentially the highest risk of hypoglycemia in the oldest. Let's have a look. Now, here are the data. So 3 groups, the 3 age groups. I think, let me draw your attention just because of time. The thing we're really interested in is moderate or severe hypoglycemia. So linagliptin 7% versus 31% in the youngest group. 6% versus 32% in the middle group, and 5% versus 27% in the oldest. So you might think, wow, the percentages are slightly less in the oldest. But the one you want to look at is severe hypoglycemia, and this was defined at anybody who needed assistance. So 0.2 in the linagliptin less than 65 versus 1.3. So that's, it's the overall, it's about a 5 to 6-fold difference, but that's still around about 1 in 80 for the glimepiride. 0.5 versus 1.9, again, 4-fold difference. But in the oldest age group, again, age increases risk of hypoglycemia. Linagliptin 0.5 versus 6%. So 1 in 16 in the older people had hypoglycemia with glimepiride. So that kind of fits with our clinical scenarios that maybe we should be slightly careful using sulfonylureas in the older individuals. So, conclusion, CV mortality was similar with linagliptin or glimepiride across age groups. There was a significantly low risk for hypoglycemia, as was in the primary study with linagliptin, as well as, I didn't show you the data, modest weight loss with no difference across the age groups. So the benefits in terms of sugar hypoglycemia were relatively similar. There were fewer falls or bone fractures with linagliptin than glimepiride, presumably because of more hypoglycemia in the older age group, and reduced risk of falls in participants aged 75 years or above, I'd imagine. And collectively, as I say, these provide evidence that there are important safety considerations when selecting therapy, particularly for the elderly above 75, at least as above 75 in the context of Carolina. Most of the older people presumably were more of a white population, but we can come back to that in questions as it refers to the sort of Asian population in India. Okay, keeping with the same drugs, this is now adding linagliptin to glimepiride in patients with HNF1 alpha, diabetes MODY3. As you know, sulfonylureas do well in this patient population. And what the investigators asked was, does adding linagliptin lower the variability in glucose in this patient population? My mind is that a question worth actually asking? I don't know. I'm not an expert in MODY, but let's have a look at the results. So they used a low dose of glimepiride in combination with linagliptin, and it was a crossover trial. And the primary endpoint's differences between treatment in the mean amplitude of glycemic excursions. So how much they varied up and down over 6 days of continuous glucose monitoring. This is what the actual figures look like. So this is baseline before treatment. And then you add glimepiride. Yep, sugar comes down, still a bit of variability. And then you add linagliptin, comes down perhaps with an eye of faith even more, perhaps less variability. But overall, there was no clear difference in actual in MAGE, or the kind of amplitude of glucose excursions. When they looked at other endpoints, they looked at the standard deviation. Now, the standard deviation is another way to measure variability. That was less when people were on the combination of glimepiride and linagliptin, as was the coefficient of variation, which is the standard deviation divided by the mean. So it's pretty much the same thing. You know, if you're going to see significance in one, you're going to see significance perhaps in the other, by and large. And there was less in those who had linagliptin. The overall mean glucoses, so baseline was about 9.5 on those who were only on glimepiride, around about probably high 8, and those who were in the combination maybe around about 8. But, you know, no significant difference. Maybe a modest, slightly modest, but it's not clear. Reductions in hemoglobin A1. Actually, this was more clear. So there was a significant improvement in hemoglobin A1. Notice the hemoglobin A1 is actually modest in patients who were given glimepiride. It was about 50, probably about 53, and it fell to around about 48 to 47 in those who were given linagliptin. As always, 2 drugs are better than one in lowering sugar, and you see that in MODY patients, and maybe slightly lower weight. So a sort of modest benefit in glycemia with adding linagliptin on top of glimepiride, and a modest improvement in variation, although not the primary endpoint. This is how I would take it. Whether that's clinically relevant, I don't know. Let's ask that question to the panel at the end. So linagliptin as add-on treatment to glimepiride, with which HNF1 alpha is efficacious modestly and reduced the daily glimepiride dose as well without increasing the risk of hypoglycemia. That's actually, I didn't talk about the dosing, but that kind of broadly fits. 2 is better than 1, is always as I see it. Okay, what about empagliflozin? Now, going back to the EMPA-REG outcome study, this is a study that is, again, a secondary analysis of the EMPA-REG outcome. And here they looked at, were the benefits the same whether the patients had BMIs below 25, 25 to 30, or above 30 on mortality and cardiorenal outcomes. And they had a special look at the same question in the subclass of people defined as Asian. Now, that Asian, I don't quite know how they, the Asian classification for FDA often also includes the mixture of South Asian, Southeast Asians, Chinese. So it's probably a broad category, but nevertheless, we know that Asians generally get diabetes at lower BMI. So were the benefits consistent across these classes of BMI? And the answer simply was, yes, it was. So hazard ratios for all-cause mortality, all on the left-hand side of the line in all patients, and it's the same in people who are Asian. The numbers of events in some of these are very small. That's why the confidence intervals are wide. But notice all the point estimates are on the left-hand side, and there's no interaction. So we cannot say that they're any different. For CVD death, again, all patients, no difference by BMI, and certainly no difference in the Asians. And if anything, the point estimates for all Asians are somewhat to the left. This is CVD death or hospitalization for heart failure. And this is kind of interesting because in both, and I'm going to present you the data, in both DAPA heart failure and EMPA reduced, there did seem to be a slightly greater benefit in South Asians and Blacks compared to whites for the reduction in CVD death or heart failure hospitalization in those groups compared to whites. So maybe they do work better in South Asians or blacks. We don't know. I think those are they were pre-specified subgroups, but they were not, obviously, they're more hypothesis generating. What about nephropathy? I think the nephropathy is very consistent. You can see the point estimates vary the least. So I think we can say with absolute conviction that you get cardiorenal benefits, whether you're Asian and also whether you're an Asian with a BMI below 25. And that's kind of important because many of our Asian patients, often develop diabetes younger, have an extra 10 to 15 years of hyperglycemia, and microvascular endpoints, particularly renal, and are bigger factors. And it looks like these drugs will slow renal decline in that population group. So that's very important clinically. So conclusions: EMPA reduced all-cause mortality, CVD death, heart failure, the combination of CVD death, heart failure, hospitalization, and incident or worsening nephropathy across BMI categories, including BMI below 25, and it seemed to be similar whether in the overall or Asian populations by those BMI cutoffs. Okay, what about the 2 heart failure trials? Now, I'm happy to talk about it because one of the heart failure trials, DAPA heart failure, was led out of Glasgow. I wasn't involved in it, but it was led by John McMurray, who sits next door to me. And EMPA Reduced was led by an executive committee, but I was also involved in this, so I know about both these trials. So the first was published last year, dapagliflozin 10 milligrams versus placebo, 18.2 months, and the primary endpoint was time to first CVD death, hospitalization for heart failure, or urgent heart failure. In this case, the primary outcome was in EMPA Reduced, time to first CVD death or hospitalization for heart failure, on top of standard of care. What did they see? Well, both trials showed almost identical results, a roughly 25% reduction in subsequent heart failure hospitalization or CVD death. As I said to you, that happened on top of standard of care. Benefits to safety ratio were excellent. Both drugs have single dosing, and as I'll show you, the benefits were the same, whether the patients had baseline diabetes or no diabetes. Just as I'm not going to go through this in detail just because we don't have time, but were there any differences between the 2 trials? The evidence suggested that perhaps there was somewhat more people who had higher BNP and EMPA Reduced. There was more people on ARNI, around about 20% on ARNI compared to 10% in DAPA heart failure, and slightly more people around about sort of 42% versus 34% on devices. So perhaps better treated in the EMPA Reduced, slightly higher BNP, although interestingly, less hospitalization for heart failure in the previous year. But that might relate to the fact that they were on more sort of ARNI and devices in the previous year. So slightly different populations, but the mix maybe gives us the answer. And the left ventricular ejection fraction was slightly lower in those who were in EMPA Reduced versus DAPA, but not much difference really. Oh, this is the primary outcome I've already showed you. This is the outcome by baseline NYHA class, and there was suggestive evidence that in those people who had NYHA class 2, which formed the predominant of the population in both trials, that the hazard ratio was somewhat better, 33% reduction in the primary endpoint compared to 13% reduction in the primary endpoint in people with class 3 to 4. So somewhat better in class 2 than 3 to 4, but suggestive evidence. Oh, sorry. What about CVD death? Well, CVD death was significant in DAPA heart failure alone, but not in EMPA. The meta-analysis suggests maybe about a 14% if you believe that the 2 differences are differences by chance. There was no interaction, so we cannot say that they are different by chance. There was no interaction, no difference in all-cause death, although it was nominally significant DAPA heart failure, perhaps not in EMPA Reduced. But again, perhaps a 12 to 13% reduction in CVD death, in all-cause death and CVD death is what we, from the 2 trials, is probably what we are probably seeing. So greater benefits in heart failure, hospitalization, somewhat more modest benefit on CVD death with these drugs. And maybe slight variance, but the slight variances might come from the slightly different treatment baseline populations, more RNA devices in this population. I don't know. People are guessing. It also had less power in EMPA Reduced, so who knows? Here's the diabetes data. If you didn't believe it, In people with diabetes, clear benefits, 26% reduction. But really amazingly, in people without diabetes, almost identical 25% reduction in the primary endpoint. So, and the P interaction, of course, is nowhere near significant because they're almost identical. What about kidney outcomes? This, in contrast to the CVD death, which was slightly better in DAPA heart failure, the primary endpoint, first composite kidney outcome, which is a worsening EGFR, renal replacement therapy, or a renal death, was slightly better in EMPEROR reduced, so a 48% versus a 29%, but overall maybe 40% reduction in renal composite endpoint. And that's really important because this is one of the very first classes that really significantly improves kidney outcomes in people with heart failure. If you compare this to ACE inhibitors, for example, in your mind. So, and the benefits of in kidney outcomes in other studies like DAPA CKD was the same whether or not the patients had diabetes. So that's really interesting as well. Here's the actual change in EGFR from the EMPEROR reduced. This was not put in the primary study, but notice this, the EGFR after the initial dip declines far less in those on empagliflozin compared to placebo. And after you stop the drug, the EGFR almost goes back towards the same at the end of the trial. So about 1 mil per minute less compared to 4 mils per minute less in the placebo. So around about 3 mils per minute difference if you stop the drug at the end, suggesting that these drugs are protecting nephron against nephron death. The conclusion of all of this clinically is that there are now 5 pillars of treatment in HFrEF, heart failure with reduced ejection fraction. So you have ACE or ARB, or the combination of ARNI, beta blockers, MRAs, and now SGLT2 inhibitors. And I asked John McMurray, which would he use first, this or the ARNIs, or neprolizing inhibitors? And clearly these drugs had a good improvement in symptomatic improvement, which was really, it was actually quite pronounced, such that many cardiologists said that the benefits in QCCQ, which is the measure of symptomatic performance, was almost as good as devices. There was this easy dosing and monitoring, this less acute kidney injury, not more. There are CKD benefits, and in terms of DKA, there was none in EMPEROR reduced, and there was only 3 cases of DKA in DAPA heart failure. So the drugs are fantastically well tolerated in this population. So I'm not going to go over this, but you can see I've said everything in this, but clearly these drugs provide a new class of treatment for people with HFrEF and have advantages over other drugs in the class and should be part of the treatment paradigm going forward. I'm actually going to go through this very quickly. Basically speaking, there was just a study looking at bidirectional association between obstructive sleep apnea and diabetes. What did they find? Well, if you had diabetes, if you had prevalent diabetes, which was absent or present, if you have type 2, you have a borderline increased risk of obstructive sleep apnea, roughly about 24 to 12%, borderline significant. So, however, if you had obstructive sleep apnea, the chance of developing diabetes, I think this is right, I need just to double check, was around about 70 to 80% higher. So obstructive sleep apnea gives rise to a higher risk for diabetes, and that makes sense because many people who have obstructive sleep apnea have evidence of obesity, and I suspect obstructive sleep apnea is a measure of ectopic fat within the neck, in the same way that you have ectopic fat in the liver, pancreas, that leads to diabetes pathogenesis. Prevalent diabetes versus OSA, as I say, modest risk, but suggesting there is a bidirectional relationship, which shouldn't surprise any of us. And I'm not really sure what the clinical implications of that is, because we treat both conditions, and weight loss is the kind of one of the treatments. But anyway, we can come back to that in the questions. I'm not really sure what the big point of all of this is. Last 2 trials, I think we're okay for time. Yep. Remission of type 2. I'll go through this relatively quickly. What did it do to pancreatic morphology? Well, in people with type 2, in people who die, if you look at the pancreas, it's often shrunk and it's morphologically irregular. in this study, it's a sub analysis of the direct trial, which I was involved in, and so I helped write this. I actually give lots of statistical comments, made sure we got it right. And I don't think it's a home run, but it's a very suggestive study. So Roy Taylor in Newcastle, they looked at pancreatic volume and irregularity of the pancreas, and we compared people who underwent remission compared to the control group. What did we find? Well, we found that the pancreatic volume in those who underwent remission improved. At 24 months, the pancreatic volume had increased by 12 cubic centimeters in responders, i.e. those who underwent diabetes remission, compared to 4.5 in non-responders, highly significant. We also found that the tortuosity improved, so the pancreatic borders were normalized, they were less kind of irregular. And also we found that there was less intrapancreatic fat. So by losing weight, you're sucking fat from the pancreas, you're allowing the insulin sensitivity improve peripherally, you may be reducing the trophic insulin effect, and the volume of the pancreas increases back towards normal, and the regularity of the pancreas tends to increase towards normal. This paper is in Press in Lancet Diabetes, so have a look at it when it comes out. As I say, I don't think it's a definitive paper, but it's highly suggestive. And that paper comes on top of other measurements where we've actually shown improvements in beta cell function using clamp techniques following remission. So diabetes is not inevitably chronic. It can be reversed early on within this first 6 years, at least in white population. We've got some data in South Asians in Glasgow suggesting it can in South Asians. The Digimed study in Qatar shows benefits that you can have diabetes remission. So weight loss in people who undergo remission, low-calorie diet, is now part of the toolbox for some people. So the final study, Virtus CV. So this was ertugrofloxacin. It happened, it's the 4th trial in people with diabetes and existing cardiovascular disease. The primary endpoint is MACE. Secondary endpoints are the usual CVD death, heart failure, hospitalizations, or renal outcomes. What is top-line results? So three arms, placebo, ERTA 5 or ERTA 15 milligrams. What did they find? Well, the results were somewhat disappointing compared to the other SGLT2 inhibitors. The one area that was completely consistent was this: heart failure hospitalization was improved by about 30%. The renal outcomes was kind of half what we expected, a 19% benefit, non-significant. So maybe cardiorenal was similar, but slightly less renal, similar heart failure hospitalization. And that MACE benefit was the least of all the other 3 trials. It was 0.97. So, it wasn't significant. And the average of the others was around about 0.86. So if you put that into context, it's slightly out of kilter, although the confidence interval does 0.85. So is this chance that it's less benefits here? I don't know. But it just looks slightly less well. Having said all of that, all the point estimates are on the left-hand side of the line. So, and it is giving cardiorenal benefits. So that's kind of reassuring. CVD deaths, no difference, although point estimates below 1. Heart failure hospitalization, 30% reduction. If you compare it to the other trials, EMPA-REG outcome, Canvas, Declare, as I said to you, the point estimate for MACE, 0.97 compared to 0.86, 0.86 and 0.93 in the other 3 trials. For non-fatal MI, it was 1 compared to below 0.9 for all the other 3 trials. And for composite renal outcome, 0.8 versus 0.5, 0.6 and 0.54. So for some reason, despite the populations we think being similar, slightly less on the kind of renal MI, but similar on heart failure hospitalization. So I don't know why that is. Is this chance? It could possibly be, but it could also be a class effect. Having said that, cost does matter, and we can come back to that in the questions. So I think we're bang in time. I'm not sure there are any more slides. So Virtus CV achieved its primary endpoint of non-inferiority for MACE, but it didn't achieve superiority. But the same was seen for Declare. We didn't achieve superiority. It did provide further evidence of safety, and it adds evidence of benefit, particularly for heart failure hospitalization for these drugs. And that fits with what I've already shown you for the 2 trials of DAPA and EMPA on heart failure hospitalization in people with existing heart failure and HFrEF. And it did provide evidence of kidney endpoint benefits, although that wasn't significant, but it's on the left-hand side of the line. And ertugrofloxacin was associated with decreasing the risk of sustained 40% decline in EGFR with less albuminuria. I think that was probably post-hoc, but I haven't seen that data. But Cardio-renal, maybe less MACE, maybe less renal, I don't know. But again, something for discussion. You know, is this class compared to the others? Is it not? Ideally, we would love another trial of using ertugrofloxacin in people with heart failure hospitalization or CKD, just to have a look. And I think at that point, oh, actually, no, there is one other trial. In fact, Mr. Chairman, if you allows me, I'll do this very quickly, actually. The Liberates trial. You give me a lot of material, but let me go through this very quickly. To examine the role of glycemic monitoring, improving glucose control after heart attacks in people with diabetes. It's a very small trial. I'm going to cut to the chase. 141 patients, 72 randomized to the control group, which was self-monitoring blood glucose, versus 69 who were given flash monitoring. More than 50% were on insulin. Quite a few were also on sulfonylurea. Primary endpoint, time and range. And to cut a long story short, there was a suggestive evidence of benefit of time and range. There was suggestive evidence, maybe significance of hypoglycemia in the non-insulin treatment arm, but that was about it. I wasn't fully convinced by the trial results, actually. Let me show you the data. I'm going to go skip that. This is the overall, favors intervention whole group, potentially for time and range insulin. But look, confidence intervals are really, really wide. If you looked at the hypoglycemia, that was more. It was more impressive for SU compared to insulin, but again, it wasn't, I don't think, quite significant. No difference in hemoglobin A1. So modest increase in time and range with flash monitoring, 17 to 28 minutes at 3 months post-ECS, but failed to reach the pre-probability significance. There was this non-significant increase and significant reduction that occurred in hypoglycemia with flash monitoring compared to SMBG at 3 months. And there was no difference in hemoglobin A1. And my context is too small to make any clinical inference whatsoever. Actually, there's a suggestion of improvement patient satisfaction, but overall, flash glucose monitoring was associated with greater treatment satisfaction, but that's not enough. If you look at the number of deaths, which to me would be the real hard point, there was 2 versus 5 in those who had flash monitoring versus SMBG, far too small to make any clinical inference. And also, if you look at MACE rates, they were higher in the flash monitoring versus the SMBG group. So my overall conclusion here is it tells us nothing. I don't think we should move to flash monitoring this group. Actually, what you should even maybe think about, and I'm being very controversial, is actually, can we reduce insulin dose by prescribing either GLP-1 or SGLT2 in this group? There are 2 ongoing trials going to test SGLT2 commencement and post-MI, and that might allow you to be insulin sparing. It might allow you to consider whether patients or not need sulfonylurea in that post-MI state. But that's very controversial. I will stop there. I think that is my last slide, and I'll pass it on. And lots of room for questions in the subsequent discussion. Thank you very much.
Thank you very much, Professor, for being bang on time. And I see Professor Melanie Davis is in. So welcome, Professor. We've already had a brief introduction, and I repeat, Professor Melanie Davis has been to India, and the Indian audience is very, used to her, and they admire her, and they respect her, and they love to hear her. So thank you very much for being here on this webinar. And I hand over the floor to you for your presentation.
So thank you, and hi Naveed, it's really nice to see you as well. So thanks very much for the opportunity. I may overlap slightly with Naveed, but I'll push through the bits where we overlap, if that's okay. So I just need to find my first slide. Sorry. 2 seconds. So you can see my slides okay and hear me okay. Is that okay? Yeah, perfect. So, yep. So apologies if there is some overlap with Naveed's presentation. These are my disclosures. It was a really busy time at the EASD, and I've sort of picked out these 6 areas: the addition study, which we were involved in Leicester, Vertis CV with the SGLT2. So I'll go through that really quickly because Naveed's already covered that quite nicely. semaglutide for obesity. There were some sessions on COVID-19 and diabetes, a good session on precision medicine, and a study on Ramadan and diabetes. So first of all, the addition study. So this was a study that is quite close to our heart in Leicester, because we were one of the UK sites. So this was a study with Cambridge, Leicester and colleagues in Europe. In this study, we screened patients for diabetes and then randomized them either to routine care or to not aggressive management, but early multifactorial management. So it was like a Steno study, but in screen-detected patients with diabetes. And this is the 10-year follow-up now, and Simon Griffin showed that. And essentially what we showed was a 13% reduction in the composite cardiovascular endpoint, but it didn't reach statistical significance. But as you can see, there does appear to be some separation at about 4 years of follow-up. And patients weren't actively followed up after the first 5 years, so they were left to get on with things. At this long-term follow-up, there were, for those patients who were available, there were still improvements in both groups in blood pressure and lipids compared to baseline. Remember, these were screen-detected patients, so actually screening appears to help in terms of getting patients well controlled. And the intensive group also saw greater reductions in their A1C and body weight. And at 10 years post-diagnosis still had an average A1C of less than 7, blood pressure of less than 135/85, and a reasonable cholesterol. So whilst these long-term, so there's a 10% reduction in all-cause mortality and a 13% reduction in cardiovascular mortality, whilst this wasn't statistically significant, it does support early screening and early detection of patients in diabetes. So Bertis, Naveed's gone through this really well, so I won't show these 2 slides that he's already shown. What I will do is just remind you a little bit about how it differed from the other study. So it was a reasonably large trial, slightly larger than EMPA-REG, 8,200 compared to EMPA-REG, which had 7,000, not as big as DECLARE. And in terms of the inclusion criteria, it was much more like EMPA-REG in that the majority of patients had, if not all, had established cardiovascular disease. So when we see differences, we don't know whether that's due to an actual difference in the agent themselves, whether it's a difference in the conduct of the study or the cohort studied. And we know, for example, in DECLARE, you know, there was a significant proportion of patients that were at lower risk in that study. But in Virtus, there were more, I think, similarities to EMPA-REG than differences. And if you look at the A1C across the SGLT2 studies, they were pretty similar. And in terms of renal function as well, almost identical mean EGFR in Virtus to the 2 studies in the Canvas program and to EMPA-REG. Again, pretty similar numbers of patients on metformin to the Canvas program and EMPA-REG. And if we look at the MACE per 100 patient year in the placebo arm of the studies, you can see DECLARE is much lower at 1.5 compared, for example, to EMPA-REG that was 4.4 and Credence 4.8. And we don't, I don't have to hand the placebo arm rates in Virtus, but you can predict it would be closer to EMPA-REG than DECLARE. And Naveed has shown you this slide, which is the primary outcome for MACE, which possibly isn't that surprising, but I think it was this second endpoint. So it was the cardiovascular death and hospitalization for heart failure, which, as you know, in DECLARE was significant, whereas in this study it wasn't. Therefore, because of the hierarchical testing, you shouldn't really go on and look at the other endpoints, but you know, people do. And there wasn't a reduction in cardiovascular death, which is not so surprising. But as Naveed has shown you, there was this reduction in heart failure and a slight disappointment in the renal composite endpoint. And this just shows that again. But just to add a couple of additional points, really from a safety perspective, I think this provides further reassurance around the SGLT2 class. There was an increase in genital mycotic infections, which we know about, but otherwise this was pretty well tolerated, and there wasn't anything to be particularly concerned about. Particularly, there wasn't an increase in amputation. If anything, there was a reduction in acute kidney injury, which we now know from these SGLT2 inhibitors. Ketoacidosis was increased a little, but we also know about that. But there was no increase in fracture and absolutely no cases of Fournier's gangrene. Now, this renal composite endpoint, I think, was a little disappointing. It failed to reach statistical significance. And this, however, if you look at an exploratory composite endpoint, which was the sustained 40% decrease in baseline, this was a little bit more impressive at 0.66. So just to put this in context, this was from Darren Maguire's slides that he presented at the end of the Virtus CV session, which I had the privilege of chairing. And if you look at the MACE, the MACE events in patients with established ASCVD, across the class, we see this 0.89 reduction, and Virtus doesn't sit so well as the others. It's, you know, it sits right on at 0.99 with really no particular signal of benefit. If you look at cardiovascular death, it's really EMPA-REG that sort of sits out from the others. And if you look at the measure for heterogeneity, it's 64%. Less than 25, we would suggest that there's not really much difference between the studies. More than 75, we probably think there is, and this sits towards that. So EMPA-REG is slightly out of kilter with the others in terms of the reduction to cardiovascular death. This slide shows the hospitalization with heart failure. And if you look at the heart failure data, if you look at the heterogeneity, the I value here, you can see it's 0. So really, I think pretty robust data across the class for reduction in heart failure with SGLT2s, which is pretty reassuring. And this was summarized in this slide here. So you can see Virtus does sits slightly outside of the others, bearing in mind that Declare-TIMI was in a much, much lower risk group. Virtus was much more similar in design and the cohort of patients to EMPA-REG, so it does look a little bit different. If you look at first glance at the renal endpoints, and of course you have to report what they specified, which was doubling of serum creatinine, dialysis, transplant, or renal death, it looks slightly out of kilter. However, and this was an exploratory endpoint, the sustained greater than 40% reduction in eGFR, but I suppose if you consider like for like across these different studies, then it looks much more in keeping with what we've seen with the other SGLT2s. So I think some food for thought with Virtus, but it's probably reassuring in terms of safety, and certainly the heart failure and renal endpoints are more in keeping with the others. Just briefly, the semaglutide obesity study I was involved in presenting this data at EASD. This is semaglutide, the weekly GLP-1, which is now relatively widely used in diabetes now, certainly in the UK. Has advantages over liraglutide in terms of its DPP-4 stability, access, and is therefore a weekly administration. And if you look at the data, this is the phase 3 studies with GLP-1s at the type 2 diabetes dose. So this is the GLP-1s, and this is the weight data. And if you look to the right of the panel where I've put the black box, you can see in the dark blue the weight loss with semaglutide at 1 milligram compared to both liraglutide, dulaglutide, and exenatide. So you can see that there's certainly a signal of much greater weight loss with semaglutide. And this precipitated a phase 2 study looking for obesity management indication, or to explore whether that would be a possibility. So in this study, semaglutide was given daily, and it was compared to liraglutide at 3 milligrams, which is already approved and licensed for weight management. And here you can see placebo weight reduction with a standard lifestyle intervention. You can see liraglutide here, what we'd expect, about an additional 5% weight loss with liraglutide at the obesity licensed dose. But with semaglutide, and this is a daily dose up to 0.4 milligrams, you can see that you're achieving double-digit weight loss. And this therefore precipitated a phase 3 program. Just to show you the sort of weight loss that was achieved in this phase 2, 80% got more than 5% weight loss. But as you go, as you look for higher percentage weight loss, you see a better comparison to liraglutide in the 3 milligram dose. So you can see virtually doubling of the numbers that get to 10% weight loss. You get 40% with 15% weight loss compared to only 15% with liraglutide. And you get a quarter of patients, 27%, with 20% weight loss. So this is a powerful weight loss drug. In the phase 3, they modeled and we suggested that it really should be a weekly administration. And so they modeled that the equivalent would be roughly about 2.4 milligrams weekly. And this is the treatment dose that's been used in the STEP program, which is the phase 3 program, which I gave the very top line headlines from. So this is a 5-month titration because you go up in 5 dose steps every 4 weeks. And the first 4 studies have now been completed but haven't been fully disclosed yet. This shows the characteristics of the patients. They aged mid-40s, BMI of nearly 38. And in step 2, they were older and more likely to be male. That's the diabetes study. And this is the headline data. So step 1 is the weight management in adults with obesity. Step 2 is the same, but in people with diabetes. Step 3 is the same design, but with an intensive behavioral intervention, including physical activity and a low-calorie diet at the beginning. And step 4 is weight maintenance after run-in with semaglutide. And you can see pretty impressive double-digit weight loss, which is by far the most impressive that we've seen with pharmacotherapy. And this data will be fully disclosed later. Just quickly, there were some sessions on COVID. This is Naveed is in fact a co-author on this Lancet Diabetes Endocrinology paper, but there was a session around COVID and Juliana Chan presented this. This is the data from using the NHS data set. Where we national diabetes audit data as well, which essentially showed that the risk of in-hospital COVID-related death was 3-fold higher in patients with type 1 diabetes compared to those without, and 2-fold higher in patients with type 2 diabetes. These estimates were adjusted for age, sex, socioeconomic status, ethnicity, and geographical region. When you additionally controlled for previous coronary heart disease, cerebrovascular disease, the odd ratio fell a little bit, but it was still nearly 3-fold higher in type 1 and 2-fold higher in type 2. This shows the unadjusted in-hospital COVID mortality rates. As you can see here, purple's no diabetes, blue, the turquoise is the overall population. Then you can see in type 1 and type 2. Just to say reassuringly, under the age of 50, the rates are really pretty low, but you can see that they accelerate as people get older. Just to look in terms of the HbA1c, really in type 1 diabetes, the A1C, once the A1C was above 10, there was a significant risk. And also once the eGFR was below 60. If you look in type 2, the risk seems to go higher, a lower level of A1C, so above 7.5. Again, this association with eGFR below 60, and also in both types a link with a BMI. So these are worrisome statistics, but there is also growing consensus that while diabetes, particularly poorly controlled diabetes and obesity, increases the risk of mortality, that we're still not completely sure about the risk of an individual's susceptibility to getting the COVID-19 infection in the first place. There was a really good session by Dan Drucker. There's been some interest around DPP4s in terms of whether, because they share a receptor for SARS and MERS, whether inhibition of DPP4 could theoretically reduce infection susceptibility. But Dan explained that there was really no evidence that this would be the case in theoretical computer modeling studies. Whilst it's been proposed that DPP4s could have an anti-inflammatory effect, there's really no evidence to support this. So he didn't seem to be particularly advocating any link with and benefit from using the DPP4 inhibitors. There's a little bit more enthusiasm about metformin, and there was some data from China showing a reduction in patients on metformin, although this was not significant for controlling for other factors. Some suggestion about insulin therapy increasing COVID morbidity and mortality, but Dan urged caution in this, explaining this is probably due to other links with more severe complications. And he really emphasized really the very basics that we should all be doing, and also supporting our patients to do to try and avoid and minimize their risk from COVID. There was some suggestion about whether there's more cases of new onset type 1 diabetes, but there was a session by Dr. Limbert who basically showed some epidemiological data from Germany showing that there really wasn't any increase in incidence of type 1 diabetes. And in fact, in Italy, it fell. She really didn't think that there was a particular risk with new onset type 1 diabetes, and also felt and also suggested that COVID is probably less susceptible in young patients as well. So just briefly, there was a session around precision medicine. So two areas here. One, a session talking about the phenotype-based subtyping, which have been looked at, which is based on 6 traits: GAD antibodies, age, BMI, beta cell function, and insulin resistance. They had described 5 clusters, which we all know about. So severe autoimmune, insulin dependent, severe insulin resistant, mild obesity related, mild age related. They noted that in the severe autoimmune diabetes cluster, there was a much quicker insulin initiation, whereas the severe insulin resistant cluster had high rates of CKD. Similar subtypes were identified across other populations, including Germany, China, US, and in India. And there was the analysis in the Indian population identifying 2 additional clusters. But I think one of the things that she did suggest was that in a recent study, actually just using age, sex, BMI, and A1C were just as effective as predicting disease course as this clustering. So perhaps not quite so much benefit as first thought. She also talked about genetic-based clustering and had this slide of 5 clusters which had been, which she had suggested, and also talked about the key genetic loci. 2 of these were clustered around insulin deficiency and 3 of these around insulin resistance. But I think it's fair to say that we're still some way off precision medicine, as in other specialities, for example, cancer and others. Finally, just a study on Ramadan, Ramadan, looking at glycoside, slow release. This was an observational study looking at 1,200 patients in 9 countries, 250 of them were from India, looking at more than one symptomatic hypo, A1C and fasting glucose, body weight and safety. There was a reduction in HbA1c, which was consistent across the groups, but essentially very similar outcomes with glycoside MR and no events of hypoglycemia. So showing that glycoside MR was safe and may have a role to play during Ramadan, because I think we've certainly been cautious about using sulfonylureas, but the slow release glycoside showed reassuring data here. And I think I'll leave it there. Thank you very much.
Thank you, Professor, for that very short and sweet and quick presentation. And I think we are bang on time. It's exactly 8 o'clock here in India. So, so now we'll start off with some questions. Now, before that, for the benefit of those who are joined late online, we have, you've already heard the 2 speakers, one from Scotland, that is Professor Sattar, and Professor Melanie Davis from Leicester. On the Indian front, we have 4 renowned specialists from 4 specialties. Dr. Sambit Das is our endocrinologist for today. Dr. Arjun Khanna is our respirologist. Dr. Chafikar is our nephrologist. Hello, sir. Good evening. We missed you in the introduction. And Dr. J.C. Mohan is the cardiologist. So what we did was we had circulated the proceedings of EASD across a lot of doctors. And we had got a bunch of questions back from them. And also there are some questions which have been posed today. So we will put them also across to you. So as I requested in the beginning, all the panelists, please try to keep your answers, to 1 to 2 minutes, per question, so that the other panelists can also reply, and we can deal with many more questions which will benefit the audience. So, so with that, let me pull out the questions that were already there in our list. Where is it? Yes. Okay, the first one. I think I have deliberately put that the first because I think that is a very important focus area for every clinician who's handling a diabetic patient. The question is, and thank you to whoever asked this question, how common are cardio-renal-metabolic diseases in primary care? So I think the time has come, thanks to SGLT2, that diabetes is no longer diabetes. There are cardio implications, there are renal implications, there are peripheral arterial implications, there are a whole bunch of implications. And therefore, this question, are they very common in primary practice? And if so, do we need to do something to educate people about it? Who would like to flag off? Professor Sambit Das.
Yeah, I think I'm audible.
Yes.
Yeah, diabetes is not about glycemia. It's actually about all the risk factors and the complications that it's associated. So cardio-renal is a very important complication. And whenever we see diabetic patients in the primary care and all our physicians, it's quite a huge problem actually. Maybe 40 to 60% will have some kind of risk factors or complications. So that needs to be addressed.
Can we have the nephrologist opinion, Dr. Chafikar?
Yeah, it's true that if you see diabetics, previously it was thought that the renal complications come up very late. But now it's known that even in type 2 diabetes, even at the time of diagnosis, we are seeing patients with proteinuria or maybe further complications. And interestingly, we are seeing subgroups of diabetic patients. So for example, if you look at the renal endpoints, we look at two things. One is albuminuria or proteinuria, and the second is the estimated GFR. So if you look at these two, then there are further subgroups in diabetics. So you can have a situation where proteinuria is not there, but GFR is low, or you can have a situation where proteinuria is there, but the GFR is normal, etc. So various combinations require different approaches. So therefore, it's very important at the time of diagnosis to find out end organ damage.
Perfect. I think that's a very valuable perspective. Thank you for that. Professor Melanie Davis, how's the practice in the UK with at the primary physician level?
Yes, so the majority of patients with diabetes are actually managed in primary care. So in Leicester, more than 80% of patients are seen in primary care. And I think, I think the COVID situation has emphasized the importance of these comorbidities. We have many patients with hypertension, with cardiovascular complications, with renal complications, with obesity. So I think anybody looking after patients with type 2 diabetes has to, be able to detect early and manage holistically, not just focus on the glucose. Of course, glycemic control is still important for microvascular complications and still plays a role, but we're looking at weight management, physical activity, lipids, blood pressure, and increasingly there's an interplay. The other area is that we're having patients with type 2 diabetes develop at a younger age and with a more extreme phenotype who get aggressive renal complications earlier. And also, if you look for cardiovascular complications, we did some MRI in these patients and they very early get diastolic dysfunction. So cardiorenal complications in these patients occur early, and we need to be supporting primary care doctors to understand and screen for them.
Okay, great. Speaking of COVID, Dr. Arjun Khanna, would you like to venture an opinion on COVID and diabetes? There seems to be some link.
Absolutely, sir. A very pertinent question in today's times, and it's probably the commonest comorbidity that we are seeing. And my unit, we were just analyzing our data. We have discharged close to around 1,500 patients in the last 2 months who were admitted with diabetes, with the COVID, and 68% of them were diabetic. So that's a huge percentage. And in fact, all the calls that I get from the discharged patients now, majority of it is actually, calls are that my sugar levels are elevated and, my random blood sugar is 250, 300. So it's a huge comorbidity.
Right.
And not only is it a very common comorbidity, it is a very common risk factor for worsening. So a lot of our patients, with COVID who have not actually done well, patients who have landed up on the ventilators, patients who've, had post-COVID fibrosis, a lot of these complications, vascular complications, majority of them actually turned out to be diabetic. And, a lot of them in our practice, for the first time when we gave them steroids, because as we all know, for COVID, the backbone of management, apart from whatever antivirals and blood thinners that we have, anticoagulants, the backbone of COVID management is actually steroids. So the precipitation of diabetes is so common in these patients. We have had 25-year-old people, 26-year-old people, previously absolutely healthy, giving them these high doses of steroids and patients landing up with impaired glucose, tolerance and bad sugar levels. So it's a big problem and we're having a really difficult time handling it. And our endocrinologists and our physician friends are really helping us. But then, it's unprecedented. It is something that we are seeing for the first time.
So, okay, this is a question open to all of you.
Dr. Amit, can I just come in here? You know, so it was lovely that Melanie you'd covered the kind of diabetes part, and I just Dr. Arjun, I was really interested to hear, you know, your experience. I think one of the implications of COVID is going to be going forward, hopefully after we come past this pandemic, is going to be a bigger focus on particularly our patients with diabetes, both prevention of diabetes and lifestyle, weight. And if nothing else, I think COVID has brought to our attention that the importance of lifestyle and obesity management, as well as managing risk factors, will keep our patients' risks escalating slower. And therefore, if they do get COVID, their chances of survival are going to be that much better. And my sense of it is obesity is a big part of it, ectopic fat. And, you know, what does lead to diabetes? People who get diabetes generally are eating too much, not physically active enough, and not as fit as well. And of course, COVID with the systemic effects makes people really insulin resistant and affects FEV1 and all, you know, tests our lung capacity, our thrombotic. And if you actually, as someone who hasn't got a good lifestyle, isn't, you know, overweight, not physically active, not relatively fit, you're going to succumb. You're going to have worse outcomes. And therefore, we should use this without giving our patients a hard time as an incentive. Now is the time to think about walking a little bit more. Now is the time to try and give up a little bit of your mitai and, you know, try and eat a few in nice ways to help people, because that's the thing that's going to be better. Now is the time to be a bit more compliant with your medications that might protect you. I don't know what other people think, but that's my sense of it, actually.
Absolutely.
So can I just comment on that? Because I think Naveed makes a really important point, because, you know, it is really important at this time to take the positives out of this, but it's at a time when the clinics are often really more difficult to run, to bring people in hospital. And so we've been doing a lot more telemedicine, video calls with our patients. And, you know, some of these patients have been very isolated, are very scared, and actually they're more likely to value that sort of relationship with their physician and their diabetes nurse. And we've had some really positive, I think, interactions with patients with type 2 diabetes, talking about the importance of improving their glycemic control, taking their medicine. You know, some of them have managed to lose weight and be more physically active during this really difficult time. So I think it's an opportunity as well as a real difficult time as well.
Okay, yeah, that's absolutely true. I think we need to take that learning, the positive learning from these negative times, and I think it will translate into much better diabetes management in times to come, because of people becoming more conscious about, you know, all the things that they need to do, and living in this closed environment, and they have very little else to think about except what to do. So, you know, probably the compliance will be much better. All right, let's move on to the next part. There's a question they want to know, explain the role of GLP-1. Explain the role of GLP-1 in diabetes and obesity and the common pathophysiological pathways. Can EMPA be used in mid-range ejection fraction? Oh, sorry, I think that's the second question. Forget that. So yeah, essentially the role of GLP-1 in diabetes, mellitus, and obesity. I think it's a question that can be answered very shortly. So
yeah, okay. So I mean, during the sessions, Lee Kaplan gave a really good talk about GLP-1 and the central effects and the peripheral effects, and, you know, the fact that obviously these drugs are excellent for patients with diabetes, but at the higher doses, particularly some of the agents, you get much more central effects and impact on satiety and you know, and weight loss, which would then get you into obesity management license. So that was the case for liraglutide. I think semaglutide has even greater access to the brain and seems to have even more weight loss. And obviously it's a weekly injection, and it's just been launched in the US and Europe as an oral medication for diabetes. So, you know, moving forward, of course, there's interest in some of these dual agonists, either with GIP or with glucagon. So I think we're going to see a whole load of these peptides, which will form the backbone for pharmacotherapy for obesity management.
Right. Okay. So essentially, the role is in controlling the glucose, in controlling the obesity, and at higher doses, there may be effects on the satiety. So I hope that answers.
Yeah, and of course, there's always also an effect on inflammation. So these are anti-inflammatory drugs as well. So in terms of atherosclerosis, I mean, if you look at Dan Drucker's overview, he would describe them as the sort of conductor of the orchestra. They have a huge number of effects, indirectly and directly, to reduce, weight, glycemic control, inflammation, and of course, whilst they're not as impressive as the SGLT2s on renal outcome, they did reduce the renal composite mainly through a reduction in proteinuria, and they can be used down to quite low EGFR. So they, as a add-on to an SGLT2, and in the future, they may also have a potential role in helping protect the kidney, although the SGLT2 data is much more compelling.
Yeah, in fact, at ADA, there was a presentation where EMPA was added on to liraglutide and gave some pretty impressive add-on benefits. Mm-hmm. So, I mean, it means that liraglutide was not working. It was just they wanted to see what additional benefits can accrue.
And just finally, I think, because it's quite interesting, the heart failure thing, I think, the reduced ejection fraction heart failure is really interesting. But of course, HFpEF, the jury's still out, and there is now some interest in GLP-1s, particularly semaglutide, in terms of whether it could be have a role in HFpEF. So don't completely discount them from the heart failure perspective.
Yeah, I would add to that. I think weight is probably a bigger factor in heart failure than it is in myocardial disease. So I think we'll find that in future trials, we'll investigate that further. But yeah.
Yeah, I think reducing obesity is a very big reduction in the risk factor for cardiovascular disease. And I think that alone justifies its use, right? Okay.
Just a small query to Dr. Malini. Like she has told GLP-1 is definitely better, but what about a condition where atherosclerosis is predominant, whether it's GLP-1 or the SGLT2? We know it's heart failure, it is SGLT2 alone.
So in the update of the ADA EASD consensus, before we'd said either or, but in the update we said that if MACE was the sort of gravest threat, then the data is stronger for the GLP-1s. It's difficult, but if you look at them in the whole, there were 4 studies that were positive, and Rewind, which did have patients with risk factors only, as well as people with established disease. If you look in the round, the data for MACE is probably slightly stronger for the GLP-1s, whereas for heart failure and chronic kidney disease progression, it's definitely the SGLT2. So I think we're starting to see, of course, in reality, in many patients, we use these drugs in combination when we're trying to get people to target. So increasingly, I think it will be a bit more academic, because if you really want to maximize weight loss and get A1C to target, often we're using combination treatment, and increasingly they're used in combination.
And I would agree with that. And also, patients with peripheral arterial disease, stroke, the benefits seem to be greater with GLP-1 as well as genesis. So yeah, absolutely.
Okay, since we're on the topic of SGLT2 versus GLP or SGLT2 and GLP, here is a possibly a stupid question, but I have a diabetic patient sitting across the table, and he's already on 3 drugs: metformin, glimepiride, DPP4, still hovering at 8.5 HbA1c, 5-year duration, and now I still have to add on something. He is obese, as most Indians are. He does not have kidney problem yet, and he does not have EASD yet. He is hypertensive, mildly. So in such a scenario, I need to think long term. I mean, that's what I would like to think long term. I would like to protect his heart. I would like to protect his kidney. I would like to protect his liver. So should I, and at the same time, weight reduction is also an issue. So should I go in for a GLP or should I go in for a SGLT2, given the composite endpoints? Now, we're not talking about individual trials showing nephroprotection or individual CVOT trials and so on. This is one patient and I need to protect as much as I can. What should I do?
I think this patient you are telling is a middle-aged male with risk factors and on metformin, sulfonylurea, and other drugs. So what we can do is we can actually give a metformin, a GLP-1, and an SGLT2. So that will be the best possible combination.
He's already on metformin, glimepiride, and a DPP-4.
Yeah, we can just stop the glimepiride or may add a GLP and SGLT2.
Okay. Any other opinions? Dr. Chafekar, what is your opinion about long-term kidney protection?
Yeah, but I think that SGLT2 are good drugs, obviously, for renal protection. However, if the patient does not have any incipient kidney disease right now, as you mentioned, and glucose control is of primary importance at this stage, and there are hardly any other risk factors, then obviously any of the drugs can be used, but SGLT2 would have an advantage for two reasons. One is control of blood pressure, and second is control of the obesity or body weight. So these two things would favor the kidney part or nephroprotection as far as use of SGLT2 is concerned. So I would still opt to add an SGLT2 to this regimen.
What would you do in the UK, Professor Sattar?
I think it's, the ideal scenario would be is if we had a simple risk score that gives us absolute risks and absolute benefits of trying one drug versus the other, on different types of outcomes, and then we can make a proper judgment. And often we're kind of basing our judgments on gut feelings that this patient has more risk of cardiorenal versus atherogenic outcomes. But in terms of this particular patient, if hypoglycemia and weight was an issue, I might bump more for GLP-1, I think certainly with the more modern GLP-1s, once weekly injections, and, particularly with semaglutide and some of the newer ones, you can get big weight reduction, good glycemic control. And there was albeit a observational analysis where they had patients it was a study by, I think it was by D'Souza et al. At the EASD. People were on 2 oral anti-diabetic agents, and they went on to either GLP-1 analog, another drug, oral agent, or insulin. And actually the ones who went on to GLP-1 analog did best in terms of getting to glycemic control and without weight gain. And if you choose one which does have a good weight benefit, the other thing is, I haven't seen head-to-heads with weight, but weight benefit, people feel better, patient-reported outcomes are better. So that probably would be my guess, but I'd like to see the patient in front of me and understand that, what their desires are. Are they happy to take once weekly injection? Would they prefer an oral tablet? Without going in either direction, SGLT2, GLP-1, you're getting similar, some types of benefits. With one, you're getting more cardiorenal, the other one atherogenic. But, starting either is going to give them benefit. Starting both is going to give them double benefit, but cost then comes into it.
Right. Dr. Melanie, do you agree?
Yeah, I think I'd want to know how high the A1C was and where the BMI is. And I think, we can't discount cost. It's really interesting because we talk about these drugs as if they're really commonly used. And yet, if you look at even SGLT2s, are still easily less than 20% in the UK, and even lower than that in some, in other parts of the world. Even in very proactive countries, it's still less than a quarter of patients on SGLT2s. If you look at GLP-1s, it's less than 10%. So we're talking here as if these drugs are used commonly, but the vast majority of people, even with established ASCVD or high risk factors, are not getting prescribed them. So that's the first thing. I think cost is still an issue, and we do need to be careful about that. I agree with Naveed. I think if somebody's BMI is particularly high, and you really want to, and also, the discussion with the patient, because, in our consensus report, we talked about that shared decision making. Is it weight that's the priority? Is it, some people are really want to lose weight and get their A1C down, in which case, a GLP-1, but you have to choose the right GLP-1 because there's quite marked heterogeneity for weight loss. If you look at for example, in the Pioneer data with oral GLP-1, actually the SGLT2 at a certain dose wasn't so different. EMPA was pretty similar in the weight loss, but the GLP-1 won slightly on the A1C reduction. So, but it would be great if they were used more, but cost is still an issue as well, I'm afraid, and access.
Okay, yeah, I think that's a very important point that's come out for the benefit of the audience. What Professor Sattar mentioned, a very important small point, it was in passing, but it's very important. You need to customize it. There is no universal rule. You need to see your patient, you need to assess the patient, and what Professor Melanie also said, you need to talk to the patient and let it be a shared thing, because the kind of patient I've described, he does not today have anything. And as Dr. Samit Das said, the kind of middle-aged patient, he has a long way to go. So compliance is a very important point. So if it's a shared decision, then it'll be adherence to the treatment and not mere compliance. So do keep that in mind, because this is an ongoing debate, SGLT2 versus GLP, what to use where. All right, while on the topic of SGLT2, what are the pleiotropic effects of SGLT2 inhibitors in type 2 diabetes and NAFLD? I'm not sure whether that's what they meant. What are the pleiotropic benefits? Okay, let's simplify the question. What are the pleiotropic benefits of SGLT2 in T2DM with NAFLD?
With NAFLD, I don't know if anybody else wants to answer, but certainly, I published the data looking at the EMPEROR program. LFTs do improve with SGLT2 inhibitors, but so do they with GLP-1. There's a number of trials of both agents now with fatty liver disease, and they do improve. We're not going to, 80% or 70 to 80% of our patients with type 2 have excess fat in the liver as part of the pathogenesis. The point where we want to use these drugs for protection is actually when they've, if you're thinking about a liver benefit, it's more often when you're worried about NASH and advanced NASH, but I think that needs a bit more sort of trial evidence and so forth. But certainly, at least the good thing is these two drugs, if you think about, and I talked about this in the Golgi lecture, my sense is, Melanie and colleagues there, Dr. Arjun, I think as we've now got in our toolbox two drugs that help weight loss, they help reduce fat in the liver. And I think they both we did need a bit more evidence. They probably help, therefore, improve patient-reported outcomes because people feel better. They're functionally improved if they lose weight loss intentionally. It's a good thing. So, and there might be other indirect benefits just because we're starting to use drugs that do help weight loss and improve. They cut fat and fuel within the body system, either by a chemical suppressant in the form of GLP-1 or by getting rid of excess sugar in the form of SGLT2. Right. And it tricks, these things don't trick the body, but they're reducing stress on various cellular factors of excess nutrition. And I think we've underplayed some of that, but that's getting too scientific. But the bottom line is, for me, I think these two drugs with their outcome benefits and the fact they lose weight and the fact they're insulin sparing and weight is good. Cost is an issue. It's just a question of who do we choose at this moment in time who can afford to choose to give clinical benefit. But interested to hear what my colleagues in India think as well, and Melanie.
Right. Dr. Samit?
Yeah, I think NAFLD has the SGLT2 inhibitors has shown reduction of NAFLD, and there was some data from Medanta by Dr. Amrish Mittal et al. Where they have actually seen by the fibroscan and also the MRI that SGLT2 inhibitor and especially empagliflozin in that sub-study that has reduced the NAFLD.
Okay, all right. Okay, let's, so here is something about semaglutide, which was, I think, what Professor Melanie talked about. The question is there a possibility of CVD-free life years with the addition of semaglutide in people with T2DM? Oh my.
Yeah, so there was an oral presentation looking at whether you could save life years. I'm always slightly dubious about these calculations, and they suggested that there was potentially 2 or 3 years, particularly in younger patients. But actually, I did ask a question because I was at that session, because we published a short report looking at the numbers of people aged under 50 in the cardiovascular outcome trials, and there's less than 1% of patients aged under 50 in any of these studies. So, you know, it's great to do these calculations, but the numbers that they would have been based on would have been minuscule, and he couldn't actually tell me the number of patients. But so I'm sure, you know, early use of these drugs, and you know, and we know from the outcome studies it's reasonably impressive. But I don't know if Naveed wants to comment, but I think some of these calculations are sort of fraught with difficulty. And, you know, I'm sure that there are long-term benefits, but I'm not sure how easy it is to calculate the sort of life years saved.
Especially since they are saying it's CVD-free life years. So,
yeah, I mean, I can answer this briefly because I was involved in that, and it sort of makes sense, because if you think about it, if you're 50-year-old and you've got diabetes and CVD, and it's a relatively small number of people, or even if you're 60, you will lose 10 to 15 years life expectancy. The younger you develop either CVD or diabetes, the more life years you will lose. So the more there is potential to gain from treatment, if that makes sense. And if you have a drug that lowers CVD risk and CV mortality, you will gain life years free from CV events. So it does kind of make sense. We're going to try and start using this metric, but as Melanie says, it's kind of intuitive. Whether we can give precise enough estimates is probably a good question. I don't think we can. But having said that, I think what people should take away is, in people who develop disease at younger ages, if we do use these drugs, they will gain more CVD life-free years. Otherwise, why would we bother giving them? You know, they're lowering CVD events. They must give you more CVD life, you know, and if you have bigger, more years to gain. The only other thing, you know, that's, to me, my mind is also that, does it also have other benefits, and weight loss and blood pressure and life in patient-reported outcomes? Quality of life, to me, matters as well, you know. So.
Okay, right. Thank you. Dr. J.C. Mohan is back. So there was a cardio question. I was waiting for you to come, sir.
Yeah.
The question is, can SGLT2 inhibitors be used in mid-range ejection fraction heart failure patients?
So we are still waiting for the data from Deliver and Emperor Preserved. In case that data comes positive, I'm pretty sure that we would be using SGLT2 inhibitors across the spectrum of heart failure. Currently, based upon data from Paragon HF, it does appear that large number of patients with HFpEF who fall in heart failure mid-range ejection fraction category are behaving like HFrEF, and it is possible that SGLT2 inhibitors would work favorably in heart failure with mid-range ejection fraction.
Okay.
Can I add to that? So,
yes.
So the PI of Deliver is John McMurray, who sits next door. And so John, I asked John this question. They said, "Are you expecting the trial to be positive?" And he said, actually, based on what he's seen, he thinks it's likely to be positive now. And remember, Deliver and Emperor Preserve, the ejection fractions, anything above 40% is what we call HFpEF. So we're not even talking about, it's anything above 40%. And I think initially we were skeptical, but I'm starting to believe that we might see a positive result in both those trials. But let's see.
Right.
Yes, that is true. The problem is, the trick is being used in Deliver. I think between 40 and 49%, you would see a large benefit, and the benefit will taper off the moment you reach more like 60 or so. And the reason is very simple. True HFpEF with an ejection fraction above 60 or 61% has much more non-cardiovascular mortality than cardiovascular mortality.
Okay.
And much less hospitalization for heart failure, but much more hospitalization. Hospitals are there, but they are not hospitalized for heart failure that often.
Okay.
Because of the primary endpoints, if you choose primary endpoint in a different way, in HFpEF also, SGLT2 inhibitor would work.
Okay. So nice hypothesis.
It depends on a smart design for the trial.
Yeah.
Okay. All right. We'll wait for the trials thing.
Yeah.
Okay. Just let me go back to the question. Okay. Considering the legacy of metformin data and its firm place in therapy in all international guidelines over the years, can SGLT2 take the position of metformin? Oh my, that's a kind of an ambitious question. So in short, over a period of time, can SGLT2 inhibitors replace metformin as the first line drug for diabetics? I think this is open to all of you because this is a truly a medical speculative question.
So I think in the fullness of time, that's probably true. However, at the moment, I think, I think metformin is incredibly cheap. It's incredibly accessible across the world. It's in all these studies that we've talked about, and I showed you the slide from the SGLT2 studies, more than 3/4 of patients were on metformin. So, and there's not really any evidence. We've just looked at this. There's not really any evidence that there's an interaction or a detriment of being on metformin if you're on an SGLT2. If anything, actually, there's an interaction with the DPP4 inhibitors to say that if those patients were on the background of metformin, the DPP4 studies would have been positive if you look at just that subgroup. So I think in the fullness of time and as the cost comes down, absolutely. But I think at the moment, it would be a mistake to say they should be just completely replace metformin.
Okay, all right. Any other opinions or shall we move on? Yes,
from the renal perspective,
right.
If you notice the GFR levels at which these two drugs are used. Now, previously, even metformin was not used at a lower GFR, but we know that the indications for metformin are now relaxed and the problem of lactic acidosis is really hyped. So therefore, even with SGLT2, with the recent trials, you can see that the lower GFR patients are also doing well. So probably from the renal perspective, I think both metformin and SGLT2 would be used at a lower GFR also.
Okay, all right. Okay, so yeah, that was a pretty bold question, I must say.
Well, right. Sorry, Dr. Amit, there is, I mean, it is a bold question. People are starting to think about doing trials in this space, but I think okay. Both my colleagues, but whether they will happen is another question, but I think, Melanie's correct at the moment. And we all know this is that the availability and cost makes the big, it's the issue. And metformin is a good glycemic drug. It doesn't cause hypoglycemia. It gives you weight loss. And ideally in the future, it might be that we'd be able to use both when the SGLT2 drug, cost comes down, to give you more weight loss, better glycemic control. Let's see. Time will tell.
Absolutely. All right. Okay. This is another one straight for Professor Chaffekar and maybe after that others also. While monitoring the kidney function in patients on SGLT2 therapy, what parameters should we use which are the most reliable and easiest to do? I mean, he has listed all of them, right, starting from blood urea, serum creatinine, eGFR, albuminuria, macroalbuminuria, microalbuminuria. He's given the entire gamut. But what is good
the
for?
Easiest, the easiest parameters which we can monitor would be obviously eGFR and the ACR, which is the albumin creatinine ratio. I think these two things should be monitored on a regular basis, like in any other patient whom you would follow up for a patient of CKD. However, with SGLT2, we know that there are chances of dehydration. So therefore, you would look for, of course, pre-renal azotemia. So therefore, urea might be disproportionately high to creatinine. So you can have a look at that. And the other thing is about infections. So therefore, in diabetics, we have seen some infections also. So as far as monitoring is concerned, we would look for urine ACR, estimated GFR primarily, and then look for dehydration as well as urinary infections on a regular basis.
Right. So the dehydration is something that the gentleman needs to add to his list. All right.
I suppose, sorry, I was just going to say, I suppose it's the question of what you're monitoring for, whether it's for safety or whether it's for beneficial outcome, really. So I think, baseline, it's always good to have a baseline measure to know what EGFR is and what the baseline status is in terms of microalbuminuria or others. But really, in terms of safety, it's really giving good advice around times of dehydration and illness and sick day rules and making sure people are aware about that. I think that's probably more important than just routine monitoring, really.
Okay. Yeah,
I just want to make a comment on that. Sorry, Naveed, one moment. The issue was of these parameters, which one you would choose to actually monitor. If you're really trying to look for cardiovascular protection in individuals, we have extremely useful data which was just published a month back in Journal of American Heart Association, looking at the analysis of MPAREG outcome. It says if at 12 weeks you see reduction in albuminuria, these patients are likely to show far greater cardiovascular protection than people who don't show reduction in albuminuria. And there are people who don't show reduction in albuminuria. So the point which the authors are trying to say is that if you really want to find out the response with regard to protection, cardiovascular protection, just look at 3 months per albuminuria, baseline and 3 months. And that is good enough actually to predict what would happen for next 3 years.
That's okay. So then, just for the sake of the audience, so if you are looking to predict cardiovascular benefit, then albuminuria seems to be the way to go. Is that what we are seeing?
No, well, I would be careful. I'd have to look at. I think we need to look at that paper. I mean, it's post hoc analysis, and not everyone is going to have albuminuria at baseline to begin with necessarily. So. It might well be true for those people, and it might be just a measure of compliance of the drug, for example. So just, I haven't seen that paper, Dr. Mohan, sorry, but it'd be good to have a look at it. What I would say, as we know, you get an EGFR dip with, and the evidence we've looked at the MPAREG outcome post hoc, and regardless of the degree of the dip, everyone got benefit, whether the dip was, more than 10%, less than 10%, or non-existent. There was no clear heterogeneity in terms of cardiovascular benefits. So that's the only thing I would say.
One more point which we should look at is the degree of proteinuria reduction. If you have a nephrotic range proteinuria and then you get a greater degree of reduction of proteinuria, that's going to be more effective as compared to a small change of proteinuria. Yeah. So the quantitation also needs to be done.
Okay, all right. So there is a different yardstick for monitoring renal disease progression and a different yardstick for predicting cardiovascular benefit. I guess for the time being, we can only summarize to that level. And once this finding becomes a little more validated, then yes, we'll possibly have a good marker for cardiovascular benefit based on renal parameters. What is the prognosis of DKA, diabetic ketoacidosis patients affected with COVID-19? Okay, Dr. Arjun, I think
I think
Dr. J.C. Mohan, you're muted. Mute.
Okay.
Dr. J.C. Mohan, you're on mute.
I think Dr. Melini has clearly shown that the death rate of type 1 diabetes is definitely more. Okay, Dr. Mohan wants to
speak. I think he's saying something, but he doesn't realize he's on mute.
Okay.
Dr. Mohan, you're on mute. Dr. Mohan, you're on mute, sir. Can you unmute yourself? Dr. J.C. Mohan? Dr. J.C. Mohan, can you unmute yourself? Okay. Anyway, Dr. Samit Das, please continue.
Yeah, I think the Dr. Naveed has presented the EASD abstract that the death rate in type 1 diabetes is almost 3-folds, and for type 2 diabetes is almost 2-folds in patients with COVID. And mostly the death rate were those in type 1 diabetes who were more than 50 years with other comorbidities. So that was probably the thing.
So I think the question was around ketoacidosis. So we have seen unusual presentations of ketoacidosis in patients with type 1 and also in some patients with type 2 diabetes. There seems to have been quite large insulin requirements required in these patients. And also, obviously, we're using dexamethasone as well, which has also required larger doses of insulin. We wrote to all of our patients on SGLT2s and talked to them about sick day rules. So we haven't had any ketoacidosis related to the use of SGLT2s in our hospital, or if I think there was one case, but it was in a patient with type 2 diabetes, and had other very severe comorbidities. But I think we do need to be careful to make sure that any patients on SGLT2s have got really good sick day rules, and if they get symptoms of COVID, that they stop their SGLT2 and really implement their sick day rules, because that is the risk, I think.
Yeah, can I ask this, Melanie? So how sick do you need to be? I mean, presumably, if you've got mild sickness, if you're able to drink and eat okay, I presume you just carry on. It's only
so we sent a letter out and said, if you're feeling unwell and you're not eating and drinking as much as you would normally do, or if you're uncertain actually, then stop, hydrate well, but get in touch with us. And we gave them all their contact numbers, and we didn't have any issues. I'd rather the patient stopped and sought advice than carried on and was poorly. And as you know, in the UK, although we didn't do this, but there was a suggestion that anybody with type 1 diabetes should stop the SGLT2. Actually, I don't have loads of patients with type 1 on SGLT2s, but we do have a few. But we wrote to all of them. In some ways, I'm not so worried about them because they can adjust their insulin and they're more used to knowing what their sick day rules are. I'm more worried about the type 2s who may not be so aware, but we got them all ketone testing and we're very proactive.
All right. Okay. There was Dr. Arjun. Okay, you're back. This question was also for you. The problem of managing DKA patients, the prognosis of DKA patients affected with COVID-19.
So, frank, ketoacidosis per se is not very common. We are seeing patients with deranged sugar levels and absolutely uncontrolled sugar levels. Patients are coming in with sugar levels of around 400 routinely. And but to say frank, ketoacidosis with metabolic acidosis, that percentage is very less. But yeah, we've had a few patients with active COVID and DKA. And the more the comorbidities, the more, the amount of acidosis, the worse the pH at the time of presentation, the worse is the outcome. So normally, when it comes to other diseases, management of DKA, we do fairly well. But somehow managing other comorbidities with COVID is not all that simple. A lot of these patients, because, the backbone of therapy in patients with severe COVID, especially the ones who've landed up on the ventilator or are in the ICU, is steroids. And at times, we've had to pulse them with very high doses of steroids. Now, added to that, DKA, uncontrolled sugar levels, and, impaired glucose, that really adds fuel to the fire. And we have a really tough time controlling these patients. So frank DKA per se, sir, is not that common. But yes, when we do encounter it, it's quite difficult to handle because we would not be able to really hold back our steroids because that leads to respiratory failure, worsening of the respiratory failure.
Okay. Dr. J.C. Mohan, sorry, we were trying to contact you because you were talking something, but you were on mute, so we could not, hear you. So, would you like to repeat what you were?
No, what was the issue? What was the issue? I think we did discuss with Dr. Naveed Sattar the issue of albuminuria as a surrogate marker of response, and he said he would like to look at the data and maybe it is a subgroup analysis. It is only a hypothesis generating. You can't really take it serious. That is where I switched off actually to the other side. Anyhow, tell me if there is any question.
No, that's right. Okay. Because we could see you talking, but we couldn't hear you. So, and it was on mute, so that's why. All right, we'll move on. Yes, what are the precautions that should be taken in diabetic kidney disease in this pandemic situation, if any? Dr. Jafikar?
Yeah, the precautions are actually general precautions which we need to take to prevent renal injury. So the most important thing would be, of course, taking care of your intravascular volume. And for that, either oral or intravenous hydration is very, very important. Looking at the nephrotoxic drugs, if there are any, they should not be used or they should be monitored. The third thing which you can do is, of course, monitor the urine output in a COVID-19 situation and detect a fall in GA. If it's a multi-organ failure, then you start getting fall in GFR or renal failure. And the fourth thing which you can do is, of course, look for secondary infection, which might set in because you are using large doses of steroids. So if that is the case, then again, that also needs to be treated early. So from the kidney disease perspective, these 4 points are very, very important as far as management is concerned.
Perfect, great, wonderful. All right, any additions to that? I think that's pretty okay. Here's a very unusual question. Can we use a combination of pioglitazone and statin in a type 2 diabetic affected with COVID? I'm not sure why somebody would ask that, but that's a question. Combination of pioglitazone with statin in type 2 diabetes with COVID. And I mean, frankly, if there's no answer, we'll just move on.
Thank you, Dr. Pooja. Thank you.
Okay.
Yeah, I don't understand why that question. I mean, the problem with lots of drugs, there are, what I would say is, as we said before, managing risk and reducing risk factors in our patients, good compliance with statins, blood pressure, the diabetes drugs, lifestyle, is the way to prevent people once they get the infection to have a worse infection. Once they get the infection, does any particular drug benefit? We just don't know. There are randomized trials on the go with SGLT2, I think. I think one of them is being led partly by Kamlesh Kunti, certainly in the UK. I think, and there are, and I think there's also a randomized trial of metformin. So all we have is observational studies and pharmacoepidemiology, and that is fraught with danger. So I don't think we really know. I don't know if Melanie, you want to say anything else in that?
Yeah, so there's I think it's called the DARE study with dapagliflozin in patients with respiratory. That's really struggling to recruit in the UK because it conflicts. We have a big platform study called Recovery, which is across all of the nations in the UK, which obviously led to the dexamethasone publication and is being prioritized in all of the UK hospitals for recruitment. So other smaller studies, it's difficult then to recruit because all of the COVID patients are prioritized to go into this main sort of platform with either phase 2 new drugs or phase 3, which are more sort of repurposed medicines that we already have. And that's been incredibly successful strategy. So that's why I think the DARE study will slightly struggle in the UK. But it's being run by, I think, Mikkel out of from the US.
I think just to add that metformin has shown evidence of reduction in mortality, in hospital mortality.
Yeah, right.
Yes, so I showed you, I think in my slide, I mentioned that Dan Drucker talked about that, the Chinese data. But actually when you adjust for other confounders, then you lose, I mean, that's the problem. There'll be lots of associations of things which look interesting, but that was observational, not subject to a trial.
Great. Yeah, that was more a retrospective analysis. So.
Yeah, we're seeing something similar in the UK data, which is something that Cummins is leading. But the problem again is, I mean, even if you adjust for everything, you still see that metformin associated with lower risk. Part of the problem, though, is it could be indication bias or other biases. You know, people who generally don't get metformin are those with poorer kidney function, those who are potentially, you know, heart failure, risk factors that give higher COVID. So there might be something in the metformin study, but I don't think it's definitive by anywhere near, you know, definitive.
I think more work needs to go into it.
More work, and it'd be brilliant if you had a randomized trial, but it's almost impossible to do that.
True. Yeah, not with COVID. All right, these are some online questions that have come just, now. This is specifically directed to Dr. Naveed and Dr. Sambit. What is your opinion on early combination of Lina and glimepiride in, oh my God, pre-diabetes and diabetic patient after metformin? Oh, I think this is two questions. Let's address it one by one. What is your opinion of early combination of Lina and glimepiride in pre-diabetes?
I think in pre-diabetes, both the drugs should not be given. There is no point in giving SUs, it's contraindicated. And Lina also we should not be giving. Only pre-diabetes we can give metformin if there is a concern.
Okay. Dr. Naveed, you were also one of the...
No, I think Dr. Samit said it lovely. I mean, you know, why would you give a sulfonylurea in pre-diabetes? It doesn't make any sense. You know, and actually the reality is, you know, there is a big prevention program going on in the UK. If we get people at the right time and motivate them, particularly in the COVID thing, if we can motivate people at risk of diabetes with pre-diabetes and help them not develop diabetes, improve their level of activity and fitness, I think some individuals might, if they get COVID, do better than they would if they didn't, you know. So, and whether metformin also helps, I don't know, but certainly metformin is the only thing that's indicated or licensed for pre-diabetes in the diabetes, you know, at the moment.
Great.
I think the question should have been like, what could have been the future role of a SGLT2 in a pre-diabetic condition? So,
yeah, right.
there might be some.
Okay, would you like to answer that? Because that's an interesting question. The role of SGLT2 in a pre-diabetic, if any. I mean, there's no evidence, I know.
No, there is some evidence actually from DAPA-HF, the non-diabetic individuals. There is a 32% reduction in new onset diabetes in those who did not have diabetes to begin with, and 32% and statistically significant. We know that in Emperor Reduce that number is only 14%, but nevertheless, it appears that these drugs are capable of preventing pre-diabetes going into stage of diabetes.
Okay. That's interesting. We must keep a tab on that. I guess.
Yeah, and of course, there's also data from the GLP-1s from the obesity program. So the scale obesity program showed many more patients significantly returning to normal glucose tolerance. In that study, around half had pre-diabetes, and similarly, I'm sure we'll see similar results with the STEP program. So certainly if you have drugs that are very good at obesity management, the issue is, I suppose, whether it's cost effective. By far the most cost effective way of preventing diabetes is through the lifestyle interventions, as shown by the diabetes prevention study and the Finnish diabetes study and others.
Okay.
All right. The only caveat, of course, with all of these studies is what we don't know is there a legacy effect? Because once you stop the drug, what happens to glucose? You know, it probably goes back to, yeah. So that's the real big question as well. But, yeah.
I think the role of the lifestyle components will probably be a more long-lasting effect than the drug.
Yeah, I would have thought so.
Okay, just a thought. I mean, since we were talking on pre-diabetes, here's a question to all of you. Like, if we were to do a study in pre-diabetics and give them metformin and follow them up long enough, is the response to the pre-diabetics who are IGT or IFG, impaired fasting glucose or impaired glucose tolerance, would there be a difference in their responses? I mean, this is a theoretical question, I know, but...
Well, I don't know if anybody knows, but the data I've seen, actually one of our colleagues in Newcastle was doing that analysis, and it looked like it was impaired fasting glucose for metformin was the greater benefit. But the reality is, actually, maybe Melanie should answer this. I mean, you're doing studies, Melanie, in this space, with, walking out of diabetes. But Melanie, maybe you should answer some of that. I mean, clearly in the UK, we're diagnosing most people with pre-diabetes based on hemoglobin A1 or fasting glucose. We're not really doing much OGTT anymore. So that question becomes somewhat mute. But Melanie, maybe you want to pick that up?
Yeah, I mean, so you make a really good point, Naveed, in that part of this is historical. If you look back at the big prevention studies in the past, they used the oral glucose tolerance test, and the majority of patients had IGT actually. And so the evidence base for IGT is pretty strong because that was, so for example, that was the basis for inclusion into many of the trials. In fact, Rory Holman did a study years ago in Oxford, which was the fasting hypoglycemia study, where they recruited people predominantly with IFG, and actually that study was neutral. It wasn't particularly positive, and people hypothesized that was it because it was the phenotype of people that came in. And if you look, whilst there is some overlap, there are some differences in people with impaired fasting glucose compared to people with impaired glucose tolerance, and your highest risk is if you have both. So there are people with IGT that have a high fasting and a high 2-hour. So I don't think we really know, and part of it is driven now because most of the people with non-diabetic hypoglycemia are based on A1C and a fasting glucose. So we'll probably never really know, and there are some differences in the cohorts, but I think in all likelihood, really good lifestyle interventions aimed at increasing physical activity and reducing weight are likely to be of benefit in both groups, actually.
Okay, all right. That was just, by the way, that was not a question. It was just something that occurred to me. All right, here's a question. What is to be known? All right, basically EMPA and LENA combination in pregnant nursing lady. Any precautions to be taken? I mean, firstly, should we use it or not? And
no, it's not licensed for pregnancy. Neither of those drugs are.
Okay, so that question goes out.
Metformin and insulin. That's what you
But
should.
that's a very important answer. Whoever asked, please don't use it in pregnancy. It's not licensed for it. Are there any foods to be avoided while taking EMPA-LENA tablets? I think I can answer that. No. I mean, we need to avoid all the sugars and the ketogenic food.
So I think the only thing I would say when I put somebody on an SGLT2, I ask them if they're thinking of going on a low carb diet. There are lots of people that have got, doing various things around weight loss. And I think it isn't a great idea to start an SGLT2 in somebody who is about to go on to a low carbohydrate diet. We see, more cases of euglycemic DKA. So I do think it's important to ask about people's general diet plans when they start an SGLT2.
Dr. Sambit, anything from the Indian perspective?
I think there is no specific food, but as Dr. Melanie has told, that many patients go for fat diets like ketogenic diet and all. So I think we should avoid using an SGLT2 in that scenario.
Okay.
The only thing I would say, there was a recent paper by Dr. Mohan and Ewan Pearson in Dundee. They looked at some trial evidence suggesting that SGLT2s have better glycemic control in South Asians compared to whites, as well as DPP4s. So that was kind of interesting. And it did make me wonder that whether in Asians, the greater carbohydrate intake means that the SGLT2s are having a more of a relative benefit, or it might be the earlier development of diabetes, the more rapid glycemia. So maybe South Asians have a bigger SGLT2 upregulation, which means that it's more susceptible to reduction. I don't know, but it's kind of interesting. That paper was published in Diabetes Care, and it's worth looking at, I think.
Okay, thank you.
I think for Indians, I can just add that because for explanation of that paper is probably we have more visceral fat, thin fat Indians, we call them. With the same BMI, the visceral fat is more, and probably the DP4 expression is more, and there is that's why the DP4 inhibitors are more active in, or it has shown at least the HbA1c reduction is better than the cognitions.
Okay. What about the SGLT2, Dr. Amit? What do you think about that?
I'm sorry?
What
why
about
would
SGLT2?
Yeah.
Well, I'm sorry, I didn't get the question.
No, I was saying, why would SGLT2s do better in Asians if it's true compared to whites?
No, absolutely. But it seems to be doing pretty good based on all the meetings that we've been having. All right, I think we are running close to closing time, but just a quick question. Once again, I think everybody is very keen on Empalina combination. Where did it go? Sorry, there's a whole bunch of questions. Yeah, should Empalina FDC, fixed dose combination, be used in renal impaired patients?
Yeah, so as far as linagliptin is concerned, we are using it anyway across the spectrum, whatever is the GFR, and even we are using it in if the GFR is less than 15. Okay. As far as the EMPA is concerned, I think the spectrum has widened now, and we are using it across the spectrum, so probably it can be used.
That was simple. All right, here's one for Dr. Mohan. What are the key considerations for managing atrial fibrillation during COVID-19?
Atrial fibrillation during COVID-19. I don't see any which the atrial. So let's talk about atrial fibrillation needs to manage two different ways. One is, of course, a rate control, and other is anticoagulation to prevent stroke. Obviously, we're not talking of rhythm control. We are not going to do some ablation or anything. Or even if you are going to do a drug ablation, you can continue to do that. With regard to rate control, there is nothing which prevents doing rate control with the regular kind of drugs. And of course, with as far as the anticoagulation is concerned, we have now data from Mount Sinai Hospital. The anticoagulation actually are quite okay. There is no excess bleeding. They have there is no failure to respond. And whether it is NOACs or it is low molecular weight heparins, of course, they don't have data with warfarin. So we don't know actually with regard to warfarin, but there is a large amount of data with this New York. The Mount Sinai Hospital has collected under leadership of Dr. Valentin Fuster, suggests that the anticoagulants can be given and they probably would be effective in preventing stroke. The only thing I want to say is we have seen in last 6 months, the good number of people who have been on oral anticoagulants and atrial fibrillation coming with stroke. Okay. And that probably is because these drugs in this highly prothrombotic milieu may not be sufficient. Initially, I was surprised, but now I keep getting these people once a week, and I'm pretty sure that we need to think more than the regular, whether we should be upping the dose, if talking of apixaban from 5 milligram twice to 7.5 milligram twice. Okay. Or alternately, you also during this phase of COVID phase, think of moving to warfarin rather than DOACs, because warfarin works on multiple coagulation factors and may be more effective actually, maybe more effective though. So these are some of my thoughts, but I don't have an answer. This is actually an interesting thing, and we need to actually. I think we need some neurologists to give us some clues about it. But as far as the stroke prevention, as far as the rhythm control, rate control is concerned, I don't think it is making any difference. People of course are getting anxious. The rate is more. You may need a little bit more of drug. Incidentally, this EASD actually brought back digoxin. So I would strongly suggest use more digoxin in rate control than beta blockers, and because of the lung and other thing. So I'm using more of digoxin in rate control in atrial fibrillation after this new EASD guideline, which has found some new love for digoxin.
Okay, all right, that's good. Resurgence of digoxin, that's good. I think about time. It used to be a pretty good drug once upon a time. I think it still is. All right, one last question and then we'll wind up. And thank you for your patience. Dr. Melanie had to leave, so that's fine. The last question is there any ray of hope for OHAs, oral hypoglycemic agents, in type 1 diabetes? young patients are waiting as they are tired of injecting insulin and getting depressed. Okay. So basically role of OHA in type 1.
I think in type 1 diabetes, insulin is still the backbone of therapy. Only thing is that metformin has been tried and it has shown to reduce the BMI and all those things who are obese. And there are data about dapagliflozin, but right now it is not approved in India to use SGLT2 inhibitor in type 1 diabetes, though there are studies which are going on.
Right. Yeah, I mean, it has also been tried in type 1, but you're right, it's still at an off-label and very primitive stage.
Yeah. Yeah, we did the removal trial in the UK led by John Petrie, metformin type 1. I mean, there was a slight benefit in weight, slight benefit on insulin dose, but it was very modest, and we didn't see any benefit on a surrogate marker of arthrogenesis. So people can use it. I think Dr. Samit, you're right, but the benefits seem relatively modest, I suspect, but maybe in some patients who are quite obese, it has more benefits. So I think you have to look at the benefit in individual patients. But ideally, what we really need is to be able to get insulin in, which is non-injectable in some other form. But they tried inhaling, but I don't think we're there yet. So that's what we're hoping for. Obviously, the holy grail, isn't it?
SGLT2 inhibitor. What's your opinion, Dr. Naveed?
I'm not an expert in SGLT2 and type 1. I haven't been involved. I mean, there are, one of the two drugs got licensed, the other one didn't. I hear some of my colleagues in some very motivated, well-educated patients, they do well, SGLT2. But I think we need more evidence in the wider use, and perhaps very select patients with type 1 is my sense of it.
Okay. All right. So with that, I think I'd like to thank all of you. And if any of you have any parting comments or some key messages for the viewers all across the globe, then we will.
Just one comment I want to make.
Yes, sir.
With DAPA-CKD, I think we should now be looking at how to use SGLT2 in whenever you want to start. Like, for example, when we started using ARBs for renal protection, we know that there could be a fall in GFR, and then we know how to use the ARBs with reduction in dosage. So a similar situation is going to come in non-diabetic CKD, where we should know how to use SGLT2 inhibitors even if there's a fall in GFR initially. I think that message has to go.
Okay, since you brought that topic up, allow me 1 minute. There was this study with DAPA, I think Diamond study, which was in non-diabetic CKD. And it was for a 6-week duration, and they were checking on the proteinuria. And they found absolutely no change in the proteinuria. And it was 0.9% to be technically, but obviously statistically insignificant. So I think there's something happening on this renal protection in diabetics and non-diabetics, because in diabetics, DAPA has shown some really remarkable results.
No, it's said to be hemodynamic, actually.
Yeah, but the benefit in DAPA-CKD was the same whether the patients had diabetes or not. There was no significant interaction.
Right, but in this particular study, the Diamond study, it's called Diamond.
But the Diamond study was not an endpoint study. It depends what you want to achieve. If you want to, protect from endpoints, it looks, from my reading of DAPA-CKD, is that it's just as good in people with or without diabetes for the hard endpoints that they want to look at.
Okay. All right. Okay, so with that, thank you all very much. And it was lovely getting your insights. And I'm sure everybody who is online would have gained a lot, and at least some of it will gravitate into their daily practices and make healthcare that much better. So thank you all very much, and look forward to meeting you once again soon.
Okay. Take care, everybody. Bye-bye.
Thank you very much. Bye.
Bye.